everyone. Thank you for taking some time out of your busy day during this lunch hour to join on our conversation today about chronic care management and health coaching. I'd also like to give a special shout out to all of those who are already involved in this grant initiative that we have that I'll discuss a little bit later. So please, if you have any questions during today's presentation, please, like Ali said, chat them into the window. I will check the chats at the end of my presentation. So if you have any immediate questions or technological issues, please send those to Ali or Wig. And then we'll open up lines at the end to answer questions. So where we can go over the next hour during our lunch today is I want to start with a framework for chronic care management. Nationally, why we're doing this and the trends of the industry. Then I want to dive deeper into what is chronic care management and the requirements for that, and then discuss a possible solution, the delivery of chronic care management, or CCM. And then at the very end, we'll open up for questions. So a framework for chronic care management. We at IRHA, we're a very diverse team that work with us all the way from the billing industry to population, public health, to administration, to clinical. And we all see when CCM was first released that this is the first transformation or first opportunity that CMS has really offered to everyone for that value-based payment model. It fits very nicely into organizations that are in the accountable care organization model, but this is a way to start that transformation from fee-for-service to value-based care. And if we look back and go back to 2008 when Dr. Berwick and his team penned the triple aim that we hear a lot about in today's literature, it's very eloquent but simple. It's improving the individual experience of care while improving the health of the population while reducing the cost of care for that population. And we're going to focus on two of these areas, access, quality, or cost. And we really want to improve access and improve quality and didn't really have a concern for cost. It really wouldn't be a super difficult activity. We could throw a lot of money at this if cost isn't a factor. Similarly, if we were concerned about access and cost but not quality, we could have really bad quality, but everyone could have access and we could keep our cost. But when we try to integrate all three of these at the same time and tackle them together, that's when we really get into that conundrum of how do we do that, or have that iron triangle of a lower cost, higher access, and higher quality. And back in 2008, Dr. Berwick said, when we meet the end for the triple aim, hospitals will be emptier, not fuller. The supply-driven care will no longer be strong, and the patient will pull their own resources. And caregivers will try to maintain and restore health and keep patients out of the system. And if I had just shown this slide very beginning and said, what am I describing here? I'm sure a bunch of chat in ACOs, CCM, CPC+, MIPS, all those new and wonderful things that CMS is releasing. But back in 2008, this was the vision, and CCM is going to help us along that journey. So what exactly is chronic care management? For the next several slides, I'll be honest, I took this verbatim from the CMS guidelines. I'm more than happy to share with anyone. I'll share my email at the very end of today's presentation, or we'll share it in the chat, my email. But CMS does have a document out saying what is CCM and what does that look like, and we're very happy to share that. I've taken these word for word from that just so you can have your own interpretation. So I'm going to discuss our interpretation, our understanding of it, but I definitely want your facility to feel comfortable with that and not just take what we say for granted. So chronic care management is a service that involves at least 20 minutes of clinical staff time under the direction of a physician or other healthcare professional per calendar month. And to qualify for CCM, you must have, or your patient must have, two or more chronic conditions expected to last at least 12 months or until death. The conditions must have a significant risk of death, acute exacerbation, or functional decline, and a comprehensive care plan has to be established, implemented, revised, or monitored. If we look at CMS's data for the Medicare population currently, this accounts for about 70% of the population to be eligible for CCM services. A little later on, we'll discuss some of these conditions that are identified. So when can you start CCM? You simply cannot call a patient and say, you qualify for CCM, can we enroll you? There's very specific guidelines of when you must consent that patient. And it must be during one of these three visits: an EM, or comprehensive evaluation management, an annual wellness visit, or an AWV, or the initial preventative physical examination, or IPPE. An IPPE is also known as our Welcome to Medicare physical. And then AWV is that annual physical that CMS would like to be utilized more often. And we'll get into that a little later on in our presentation. What conditions qualify for CCM? Here's a list of examples of those. These are not the only ones that qualify, but I would like to draw your attention to a few uniquenesses, some of the things that really excite us here at the Indiana Rural Health Association. That first condition list is Alzheimer's. It's very key here that I would like to stress with everyone that CCM is not just for traditional physical conditions. Hypertension, COPD, depression, diabetes, those all qualify as well. But Alzheimer's qualifies, depression qualifies, other mental health conditions or diseases also qualify. Also there at the bottom of the first column is autism spectrum disorder. I'd like to draw your attention to that. We understand that most Medicare patients are 65 and older and qualify for that age category, but several Medicare beneficiaries also qualify based on disability, and they do too also qualify for CCM services. So if your facility already has a initiative in place to work with that population, to work with your dually eligible, they also will qualify for CCM, assuming they have 2 or more chronic conditions. All CCM is built underneath a certain practitioner's license, so the physician or the following non-physician may bill for this, including a certified nurse midwife and a certified nurse specialist, nurse practitioner, or physician assistant. That does not mean these are the individuals delivering the 20 minutes of non-face-to-face care. In order to deliver the non-face-to-face care of 20 minutes, you must have at least an MA, LPN, or RN to deliver that care. Other services or other individuals can deliver that care, but they must be at least an MA certification. During that AWV, that EM, or that IPPE visit, you must get the patient consent for CCM before you can start offering CCM services. And what does that mean? That means you have to inform the patient that they're eligible and that this is a service eligible for them. You must have their consent. You then must have to explain to them that this is going to go in their patient records, and the patient may revoke the service at any time. And also that only one practitioner can furnish this service during a calendar month. So if they are seeing their annual wellness visit with their primary care physician, but their cardiologist is outside of your current system, you need to check with that patient and ensure that they have not consented for CCM to be delivered at more than one entity. You also must receive their consent every 12 months for CCM or annually during that AWB visit. So what does this mean? So you have to give 20 minutes of care coordination of staff time. This can be face-to-face or non-face-to-face, so it can be telephonic, but it must be direct staff time. Sending out a text message or an email alert to the patient, while that may be a great intervention to engage them in their own care, does not qualify towards these 20 minutes of care. It is 20 minutes of staff time. But it may also be if that patient has a cardiologist and the primary care office, the CCM is being delivered out of the PCP's office. If that PCP's office care coordinator calls over to the cardiology office to get more information, or calls to the hospital to get information about discharge, that time does count. It does not have to be 20 minutes of engagement with the patient, but on behalf of the patient. Co-insurance and deductibles do apply towards this, but we're finding that most supplemental and gap plans will cover this for those patients. But it is something to keep in mind that at the beginning of the year, when their copay is high or their co-insurance is high, that they may have a co-insurance associated with this. There's also uniqueness on the supervision requirements for CCM delivery between a rural health clinic or FQHC and a general hospital or general clinic. If you are an RHC or an FQHC, please be sure to know that it is direct supervision is required, which means that CCM must be delivered in the same physical address of the physician or person who is authorizing the service to be delivered. So if a group of RHCs or 4, you must have someone at each of the RHCs to do that. Hospitals, the general does require, so you can outsource this service to a call center to call your patients on your behalf, or if you have a centralized location for all your clinics, you can have them call on that behalf as well. All information that you collect has to have a structured data recording per CMS guidelines. This includes the patient demographics, the problems, medication, and medication allergies, and keep all that into certified EHR technology. CCM is very dependent upon their care plan. This is a patient-centered care plan based on physical, mental, cognitive, psychosocial, functional, and environmental assessments and an inventory of resources. We're very excited that this is not just physical health, but looks at the overall big picture for that patient, including the social services they may receive, including mental health, including services out in the community. You must be able to provide that patient with a written or electronic copy of the care plan and document its provision in the medical record. So this can be shared through a patient portal, can be printed during a visit, or securely emailed to them. You must ensure that anyone within the provider or office of the person providing the services has to have access to that care plan at all times. And you have to have plans to share that care plan electronically, again, through an EHR transformation or transfer, or email that's secure with outside practices as appropriate. That is not required to be done for every single patient. What can be listed on that care plan? CMS has left this very open to be what makes most sense for your practice or your facility in how you deliver CCM. But some examples can include a problem list, what outcomes and prognosis are they working on, measurement treatment goals, symptom management, plan interventions, medication management, that community or social services that have been ordered, a description of how different services or of agencies and specialists are working with that patient, and this needs to be periodically reviewed on behalf of that patient. Access to care, so you need to ensure that there's 24/7 access to case management services, ensuring that if that patient has an urgent need that they can get access to someone. This does not need to be direct supervision according to CMS's requirements for RHCs, FQHCs. This can be your traditional 24/7 call center that you might have on behalf of your physician for after-hour support. This can be calling into your local ED on the weekends, and they have access to that care plan. You also have to ensure that that is able to be shared electronically through telephone, secure messaging, or secure internet. You also must provide care management through this. This is the systematic assessment of that patient's medical, functional, and psychosocial needs. It's a system-based approach to ensure timely receipt of all recommended preventative care services. Medication reconciliation needs to be part of this to ensure that there's adherence and review of adherence by behalf of that patient, as well as potential interaction. You also have oversight of that patient's self-management of their medication, and then follow up with that patient after an emergency department visit or a visit to the hospital, skilled nursing facility, or other healthcare facility, ensuring that you're involving them in their care plan. So in summary, what is CCM? It needs to be initiated in at least one of 3 visits. Example is the AWV. You must receive that patient's consent before delivering CCM. That will then allow you to initiate CCM and develop that care plan on behalf of that patient, and then connect that patient to the needed resources and screenings that they need. While I understand that there are several people on today's webinar who are listening in on their phone, I will do my best to describe these next few slides, but these are visuals for those who would like to see an example of CCM. So if we imagine that the doctor's office is in the black box and CCM is in the blue box. So at that very first AWV, annual wellness visit, that patient goes through, they get their health risk assessment, you identify screenings that they're eligible for, that they're past due on, or different testing that they need done. For example, a colonoscopy, a lipid panel, a mammogram, a pap smear. You also at that time get their consent to be participating in CCM for the next year. That next month, that first month of CCM, they have their blood work completed based on their annual wellness visit. That first month starts the day after the consent has been signed. They go for their blood work. This is a great time, 20 minutes of non-face-to-face care coordination for that coach to call that patient and say, here, your blood work has come back and here's what it means. Do not be alarmed that these values are outside the normal range and they're bold or they're italicized or however your electronic health portal tracks all of that. Please, and here's what it means, and here's what we can do to help work towards improving those numbers, or here's the future testing that we recommend. Remembering that their care coordinator is going to be with them and talk with them and work on their behalf 20 minutes that month and every month to continue. The next month, they have their colonoscopy scheduled. Again, this is an opportunity for that CCM, that care coordinator, to call that patient to ensure that they're prepared for it. They have all their prep material ready, and also to discuss with them after they get the results from the GI doctor who does it, what they mean, and if they have any concerns that have not been answered. Let's then assume that over the next 4 or 5 months, things are going really, really well for that patient. They're getting their CCM. They're still checking in with them every month. They're checking in, they're working with them, working towards their goals. They've also set goals over their AWV that they'd like to lose weight, so they're helping with that motivation. And then at 6 months, their doctor is going to see them again for their 6-month checkup. That's the time where the doctor is going to be able to review, or the other mid-level who's working with them, is able to review all the CCM notes, understand what's being done, work with them, make sure they're happy with CCM, and then also help them with all of their other clinical needs. We do understand that this population, especially the high utilizers of the ED, that this intervention is not a light switch that you flip that all of a sudden that they are going to quit using the ED. It is going to take some time. So in this example, let's assume month 7 that patient does go back to the ED. This is an opportunity again for that CCM to call them after discharge to say, I see that you're in the ED. What was going on? What caused you to go to there? Why didn't you not call in? What was your concern? What can we do to help you? And what can we do to prevent this? During that encounter, everything is going really well. So for the next 5-6 months, that patient's going really well through the process. And again, that coach is with them and working with them very closely, hand in hand, working on improving whatever their goals are, and also there whenever they have questions. And then we start the cycle all over again. They do that AWV again in year 2. They get their CCM consent too, and the cycle starts again. So now I'd like to go over a possible solution in the delivery of CCM. Here at IRHA, we're very pleased of a grant that we received back in May of 2014. There's a lot of people listening in today who have participated or will participate in that grant at some point. So thank you. I encourage you to share your viewpoints of the grant at the end as well if you're willing to. But our grant was funded by the Health Resources and Services Administration, or HRSA, in the May of 2014. We're currently starting this month our final grant year, and our grant will run until April of 2017. And we're currently partnering, I need to update the slide for year 3 training members, with 13 intern members. An intern is the Indiana Statewide Rural Health Network. That's a mature network that the Indiana Rural Health Association coordinates and manages. And the goals of our grant were to improve the physical health, behavioral health, and overall quality of life for patients in rural communities throughout Indiana with diabetes, COPD, and/or congestive heart failure, while decreasing the cost of care. We piloted that in 2 initial partners, one of which is on the call today, thank you, and then we've expanded that across to several other partners of which are on the call as well today. And our grant is based on 3 different stools. One is health coach training, how to prepare our staff to be ready to work in this area, software and technology, and then evaluation to make sure that we can show to HRSA how the funds were used and the outcome that it received. Our health coach training is being delivered by the Iowa Chronic Care Consortium, or ICCC for short. We partnered with them now for 3 rounds of training, and their training is a 27-hour of online training with a 2-day live intensive and 4 one-hour coaching calls. That 27 hours of online training is didactic learning of the material. The 4 one-hour coaching calls is practice time or listening in time and interaction time. And then that 2-day live intensive is where we really apply the skills and start practicing them. We host that live intensive here in Indianapolis at our IRHA Indy office. And our training will focus on motivational interviewing, the conversation flow, goal setting, and personality type. The health coach training is a very particular set of skills enabling healthcare professionals to partner with their patients to build self-care skills, promote improved health behaviors, and inspire accountability as a path to achieve the triple aim. We recognize that the patient is the greatest untapped resource currently being used in the healthcare industry. About 90% of all care that a patient receives is done by themselves outside of a clinical setting. So this is an opportunity to engage with that patient, to work with them and set goals that matter to them, to help them support what they're doing. Population health patient care strategies to align evidence-based care with the patient-centered resources of an effective healthcare team, to ensure they're being connected to the resources that will most benefit them. So what's the passions of this training? Is to create a competent behavior change specialist. It's to build skills as a care management facilitator. It's to focus upon inspiring patient activation, self-care, and accountability. It's to prompt commitment to population health strategies and help towards patient-centered medical home standard fulfillments, and to recognize that patient as the greatest underutilized resources in healthcare. I like to highlight here that this training is a great additional training to the clinical training that our rural providers already have received. This is an opportunity not to learn what to do, but necessarily how to engage with that patient moving forward for that long-term encounter that you're going to have with that patient over a 90-day to a year to 5-year period. You come into this training with that clinical knowledge already behind you. So when that patient has a very detailed question about their medication, you're relying not on this training, but on your clinical training already. The training is designed, though, for about anyone to go through it. I personally have gone through it, and I'm not a clinician. We've had administration individuals go through it to get an understanding of it. And then we've had everything from an MA go through it all the way up to an MDDO to go through it. So it's very broad in who it can target and the skills that it can help assist in delivering. The training is highly performance-oriented with coaching practice and communication focus. The training is for individual skill development. It's not to train the trainer. We encourage each person who wants these skills to go through it. And it's to build skills for the clinical health coach, which can go by several different names of care coordinator, case manager, care navigator, health coach. It's not really for a specific position. It's for whatever role that person can fulfill within your organization's goals. The second leg of our tool is a remote patient monitoring tool and a CCM tracking tool. So we partnered with Civic Health for their tool called CareScope. Civic Health is based in Nashville, Tennessee. It's a totally web browser-based tool that everyone can use. We went with a totally web browser-based since we are in so many different facilities that we wanted to be able to make sure it had easy adoption across the facilities. We also allow patients to report in their clinical values daily, either via phone, texting, or online. And then we now have a module built into this for the billing and tracking of CMS Chronic Care Condition Management, CPT 99490. So currently under the grant, we have a lot of patients reporting in their values. So each patient reports on a scale of 1 to 5, how are you today? And did you take all your medications today, yes or no? We do understand that patients may be ashamed to report that they didn't take all their meds or may not be sure what meds they need to take that day. That's an opportunity for the coach to work closely with that patient to understand that any information that they give into the system is just there for us to help them achieve better health and not there to judge them or get mad at them. We then have the 3 disease pathways, CHF, diabetes, and COPD. For CHF, we say, what's your blood pressure and weight? Diabetics, we ask for their glucose. And COPD, we ask for what is their pulse ox. This is a BYOD, a bring your own device program. So the patient will have their own device and then put this in either via texting, calling it in, which is a voice-to-text option, or using an online system. 2 things I like to stress here, though. A, this is not a 911 system. So if a patient has a glucose level that is dangerously high and reports in at 8 p.m. on a Friday night, it may not be viewed by a coach until Monday afternoon. The patient needs to understand that this is a great way to report to their coach, to help track, to help keep them on records and everything. But if they have a value that they feel is out of range or that they need immediate assistance, they should do their traditional support, whether that be call an after-hour call center, call for an ambulance, or wherever that patient is trained. We also want to stress that you can only report one disease pathway at a time. So we know we might have some patients who have CHF, diabetes, and COPD. We feel it'd be overwhelming for them to say, what's your blood pressure, what's your weight, what's your glucose, what's your pulse ox? So at one given time, they're asked one set of questions for one disease. At any given time, it can be changed as well. Health coaches also have access to the system for a common form for patient tracking on their goals. We heard initially that some of the facilities that we were working with, their EHR was not set up to track patient goals, and it wasn't something that they had a good spot to do. So we developed a spot on the system for that. We also have a simple view, so all patients and their reported information can be quickly and easily seen on the system, and that's color-coded. So they reported a glucose at 250, that will become a red reporting. If they reported a glucose at 110, then it's green because it's in normal range. For glucose and blood pressure, we have out of range and normal range. For weight, we do smart trending. So if you gain 3 pounds in one day or 5 pounds in 5 days, according to the American Heart Association, that is an alarm. Pulse ox, we do not alarm since there are so varying levels that we would like. You can also set it up if, as a coach, you'd like to get that emailed or texted to you whenever you have an out-of-range value in a HIPAA-compliant way. And then we also have a way for CCM tracking and billing, which is something that we're just now rolling out to some of our partners. So I'd like to show you what the system looks like. For those of you who are currently using the system, you're going to see the redesign of the system. The system got redesigned back in March for CCM. We are not redesigning the grant version of the system, but if you're interested in CCM, then we would encourage you to transition over to the redesign. Or if you'd like to go to the redesign, just let us know. We'd be more than happy to do that. It's a quicker and easier way to access your patient's information. So when you log in, you're quickly and easily going to see a dashboard that's customizable to each individual who logs into the system. For this dashboard, for example, I can see how many my diseases by client count. I can see my age distribution for diabetes and hypertension. And then on the bottom right, I can see the clients enrolled by month, year to year. So here I have 2015 and 2016. So I have targets of how many clients I want to enroll into CCM or how many clients I want to complete an AWV for. I can quickly and easily track that to see where I'm progressing towards that. The system also now has a way to integrate the AWV into it. This is a spot where you're able to log in. It takes about 30 minutes for a medical assistant, LPN, or RN to sit down with that patient and have a discussion with them and a conversation with them to ask them a bunch of different questions about their health, screenings that they're due for, as well as their readiness to change. And then at the end, it spits out a report about 5 pages identifying where they're ready to change. So here we can see that this person is contemplating decreasing their alcohol use, they're not a tobacco user, and they're already working towards nutrition and exercise. Again, a great spot for a CCM coach to say, okay, I see this is where you want to start. Let's start forming a goal around that. We can also see where they're high risk for different diseases based on their self-reported information. So here we can see that they're high risk for coronary artery disease and stroke and vascular disorders, at medium risk for sleep disorders. And then beneath this, I can't get it all on a slide, you can see what screenings they're due for. So you can see that they're due for their colonoscopy, they're due for their blood work. This then is generated so when the doctor meets the patient or the mid-level, they easily and quickly have all this information in their hand to have that conversation with the patient. This is all integrated into CareScope, and then I forgot to mention that CareScope can integrate seamlessly into your EHR. So all the information that you document into CareScope can be quickly and easily every second to every hour to every day be rolled back into your EHR. In that EHR, it's not editable, but it is viewable. So all this information for that doctor can be within the EHR. They do not have to log into a separate system. We're very excited for this, of what this can mean as well. We also within CCM, so here we're looking at Johnny Castle, who's at Centerpoint Hamilton, born in 2009, so a pediatric, for example. We see that we can access all their needs there on the left column, and we can insert them into different programs. So we've assigned this person to the CCM Diabetic Management Program, which means we can now track, do we have a consent? And then we can run reports on that to say this patient is due for their AWV in 30 days, their consent for CCM is going to end. We need to reach out to that patient and engage them to get them to reconsent into the program. We also have care plans. So if your facility already has, if I have a new diabetic, here's what we're going to do on visit 1, here's what we do on visit 2, here's what we do on visit 3 to engage them in their care process. You can have all that programmed right into the system, customizable to your facility. And from here, you're able to have your coach enroll them in that care plan, and then follow the steps. If you do not currently have care plans, we do already have programmed in there the standard AHRQ pathways that have been established through the research of AHRQ. One of the things that we're very excited about for CareScope that's new to it is their resource directory. This is a spot that it does take a lot of time to input this information. That's something that the IRHA staff can help you with. But if you have a patient who says, I don't go to my doctor visit because I don't have good transportation, this is a one-stop shop for social services that that patient may need to access. Can query it based on their zip code, their county, their city, or their state, their service type, and then if you like, you can also query by their payment type. From here, you're able to see which community resources meet the need of that patient. You can map all of that, and then you can make an electronic referral on behalf of that patient all within the system. You make that referral on their behalf, and then on the other end of the system, so in this example, CAS, Cincinnati Area Senior Services is the first one. They would also have access to CareScope as well. On their end, they log into or they get an email, you have a new referral, they log in and they're able to see that referral. It's not the full patient's medical records and all that information. It might be the patient's name, their address, and some notes. This patient needs transportation to their PCP appointment on this date. Can you do that? Please reach out to the patient. This will then make for that seamless transition so you're not faxing documents or making phone calls and worrying about something to get lost. On their end, they're able to make notes back into it. So when you work with that patient, you're able to see all referrals made on behalf of that patient, see the notes, and then the next time you talk with that patient, hey, I see CAS has agreed to bring you or whatever, or Habitat for Humanity came out and fixed your draft your windows, and have a conversation with them about how that's improved their health. Like I said, all this information can be boiled up and shared into that EHR. Here's an example of one of those reports. This is a one-page report that shows their condition, the medications they're on, and allergies. There's also other detailed reports. If you're interested in seeing any of these reports, I have quote-unquote dummy samples of de-identified patients that probably will make no sense to a real clinician. I made them so they looked pretty with reds and greens and yellows. Be more than happy to share those via email. Just contact me after this presentation. Next, the area that we're really excited about, this is a screenshot of the older version. It's on the newer version. I don't have a new screenshot yet. Is how do you track how you spend 20 minutes with that patient? A lot of the EHRs are really good at saying they were in the ED. We had their annual wellness visit. We had those episodic points of care. Well, unless you're doing a lean study, you're generally not tracking how much time did I spend with that patient. This is a one-stop shop that you can go into Civic Health Tool CareScope, open up that patient, and click that default down there by that start date that's circled in red. Here, it will take the time off your computer and start that, and then you can go into your primary EHR, you can go to your referrals, you can call the patient, you can do assessments. The SF36, the PHQ-9 can all be programmed into this. That's going to score all of that. Do all that, and then when you're done, you come back here, hit that default next to end time. You have now captured how much time you spent with them. You have created notes about what you did during that time, and now that's going to spit out a report at the end of the month to your billing department to say these patients had these chronic conditions, they qualified for CCM, we had a consent on file, and we did deliver 20 minutes of care to them, of staff time care to them. You're also able to run reports throughout the month to see how many patients are within a minute of that to ensure that you're optimizing
I'm good. How are you?
I'm doing real good here now.
Um, so you're able to do all that right within the system.
Tomorrow?
Oh, yeah.
I thought we were going home on Friday.
Allie, can you mute?
Who told you tomorrow?
I got the exercise with me that they gave me.
Hey,
Exercise that to do without home. The girls gave me that.
Good.
sorry, Claire, I'm sorry I'm talking over you. So the third piece of our grant is the project evaluation piece of the grant. Since this is a HRSA-funded opportunity, we do have to make sure that we are evaluating what has been done. So our evaluation is being done through the IU School of Medicine under the direction of Dr. Hannah Maxey, with the support from Courtney Randolph and Connor Norwood. All of our evaluation tools were formed specific to our project, and all patient data that they receive is at a de-identifiable level. We have our evaluation looks at the health coaches. Are they learning the skills that we intend for them to learn through the Iowa Chronic Care Consortium's training, as well as we will start be doing coaching satisfaction surveys with them as well to see how this has changed their job and the responsibilities that they do have. In addition, we are looking at pre-surveys that our coaches are asking our patients to do based on iPads that are being provided. We also complete a repeat survey of each patient every 3 months, and then at the end of the project, we'll look at changes in ED and inpatient utilization. So in summary of the grant and a possible solution for CCM, we offer training to our staff to provide the service through the Iowa Chronic Care Solution. We have a software solution that includes documenting that consent. We have approved AHRQ pathways in there. We create an audit trail of time spent to help with the billing of CCM, and we help with the connection with that broader community. We also have evaluation tools as well for evaluation of staff and evaluation of patient outcomes. So if you're thinking about CCM, or if this is the first time you've ever heard about CCM, I want to leave you with a financial ROI calculation. What does this mean if I were to implement it at my facility? So I'm assuming, and I made a lot of assumptions here, and I'll state what those are, but I'm assuming that I have 750 Medicare eligible lives within one physician's practice. I anticipate, or I know CMS will reimburse the AWV at $140 per visit, and CCM is reimbursed at $38.88 per visit or per month per patient. I also like to highlight that we don't take into account in this calculation the AWV additional revenue that can be generated. So if they are due for their colonoscopy, if they're due for lipid panels, if they're due for mammograms, those are additional revenue sources as well for the facility for primary prevention and screening. We are assuming that 50% of the eligible patients will come in for their AWB in a 1-year period. And from there, we're assuming 32% of those patients qualify for and enroll in CCM. So 375 patients for their AWB, and of the 750, 120 are engaged in the CCM. We anticipate that that's going to be a gross revenue of around $109,000, And the software cost of the software that I just showed as an example would be around $24,000. That gives you a net revenue of about $84,832 before the labor cost is taken out. And that would either be outsourcing and coaching to a third party or having staff inside your organization to provide that coaching to your patients. But a lot of the services that you may do through CCM or be able to track through CCM might be things that you're already doing, and this is a way to capture that as a billable service. So with that, I wanted to make sure I left plenty of time today for questions. Here's my contact information. My email is cmullen@indianarha.org. You can find me also on the Indiana Rural Health Association website and my phone number. And then we also have Kathleen Shelminiak, who works closely with us on this project as well. You're more than welcome to reach out to her as well, and her email is also on here. For those of you who are on the phone, again, I'll repeat my email. It is cmullen@indianarha.org. Please don't hesitate to reach out to either one of us, either telephonically or via email. We'd be more than happy to share these slides with you, share CCM information with you, share more information about the software solutions and the reports it generates, and or to come visit with your facility on site and have a further discussion about these things that we can't really dive deep into during a 1-hour lunch and learn virtually. So with that, I'll turn it back over to Allie. Allie, thank you for allowing me to participate today on this, and please let me know if you have any questions.
Thanks so much, Cody. I do want to remind everybody, I sent out a chat during the presentation, but if you would, please use the chat function to send us your facility site and your email. This program today was provided by a grant, and we want to make sure that we keep good records for them so we can keep providing you excellent quality presentations. In the meantime, if anybody has any questions they would like to ask out loud or that they would like to send through the chat, we'll go ahead and keep the line open for at least 5 minutes if we don't hear anything, but as long as it takes to answer all the questions, if anybody else wants to come on. I did have a question about whether the slides will be available. I'm certain that Cody can make those available, but also we have recorded today's presentation and it will be housed on the IRHA's YouTube channel, so you'll be able to go back and view it then as well.
Michelle, I see that you requested the slides, and I will get those emailed off to you in the near future, either today or tomorrow. I'm seeing a question come in from Matthew Mahan. What kind of challenges have you faced incentivizing patients to engage with the program? I'm going to see if any of our sites, I think you might have a better opportunity to discuss with that. I can repeat what you've shared with me, but if any of our sites would like to discuss some of the challenges you've had, I'd really appreciate that.
It's just so frustrating, Chris.
Well, not hearing anyone, I think the main challenge that I've heard around CCM, and I'm going to focus my remarks on CCM specifically because our grant was started without CCM even being an option. We wrote a grant back in 2013, started in 2014. CCM was just released January 1st of 2015. A lot of the CCM, though, concerns that we're hearing is that there is a cost share associated with this, and a lot of patients are questioning. You're calling me, you've always called me with my information, you've always worked with me, I've always been able to reach out to you. Why am I now getting a $9 bill from the facility? So we're seeing that as a major concern. We're also seeing a lot of seeing CMS looking at that and saying, is that the best thing to have a cost share on a preventative service? And I would anticipate that that's going to change. The Senate Finance Committee in January of this year released at the federal level a report on chronic care management for the nation, and CCM was part of that. They would really like to start tiering CCM so that it gets more, so the higher acuity patients will have higher payment and maybe a higher expectation of what's done on their behalf. And I would anticipate that would be the time when CMS would maybe get away from the cost share. I see another question. What role is the pharmacy or pharmacist playing? Are you taking a yes/no on medication take? How do you ensure there's more exhaustive medication review? So right now we are working with a few different grants to study the intervention of a pharmacist, working through CCM, calling the patient. Right now our health coaches are working with the patient on a lot of their goals and not doing necessarily that medication management. But that is something that with CCM will be a requirement and that they're working on. And we're working on a solution for. Any other questions, either via chat or orally?
Okay, well, we appreciate everyone coming on today, and I do see there are a couple more questions coming on, but if anyone doesn't have any questions, Cody and I will hang around. We'll answer those questions for you, but I want to let everybody else, you can have 18 minutes back for your day if you don't want to hang around, and if you have questions or want to talk to Cody, please stay on the line.